everyone with an interest in NASH or more broadly fatty liver disease, surf's up. Season 4, Episode 2 of Surfing the NASH Tsunami, our coverage of Saturday at NASH-TAG 2023, starts now.
Today, on a special NASH-TAG episode of Surfing the NASH Tsunami.
The narrative has changed. It's been a great focus of the conference, and it's going to usher us into this new year with just a really different perspective.
Embarking on the 12, 18-month combination trials because the company has access to two drugs that are somewhat different is really wasting a lot of energy and time, and it reflects our naivete about the real pathogenesis of this disease.
We're going to be able to use non-invasive technologies to track the response to medications or to any treatment. If you can use them in medications, you can then use them in lifestyle management.
When you get into how drugs get used and not how they get approved, you start to shift your focus from what the regulators need to what the payers need.
You can see multiple dimensions of fibrosis changes. So it's not just a one-point reduction.
By applying these technologies, we're going to understand better how much change in fibrosis there is. It seems very logical to postulate that not all drugs are affecting fibrosis regression by the same way, but more specifically on how and where they act.
To kick off 2023, over 300 attendees representing the range of fatty liver stakeholders have come to Deer Valley, Utah, or joined online for NASH-TAG 2023. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and our guests, hepatology researcher and key opinion leader Dr. Scott Friedman and geneticist, Age Diagnostics CEO and entrepreneur Rachel Zayas, as they discuss what we are learning and how it will affect NASH stakeholders today on this special edition of Surfing the NASH Tsunami. This episode of Surfing the NASH Tsunami, including the accompanying discussion on zonal and liver volume-corrected analysis of fibrosis and steatosis, is sponsored by HistoIndex, the world's leading specialist in stain-free imaging for NASH clinical trials. HistoIndex is transforming diagnostic standards and drug development for NASH with its second harmonic generation-based AI digital pathology solution.
Welcome to Episode 2, our coverage of the second day of NASH-TAG 2023. Let me start by thanking HistoIndex, who's sponsoring today's programming. You'll hear a conversation with Jörn Schattenberg, their Chief Scientific Officer, Dean Tsai, and me at the end of this episode. And also, let me apologize, to you, our listeners, for two circumstances not completely under my control. First, this introduction comes on the new microphone I rushed out and bought after listening to this morning's conversation and hearing how bad I thought I sounded. My mic did not perform well during the interview with Dean and Jörn, but Mike and I thought that was just a one-off. However, when it happened again for this morning's conversation with Jörn and Louise, Mike and I decided it was a fault in the microphone itself. So in the 2 hours between when we finished that recording and now, I rushed out and bought a new microphone. Hopefully that solves the problem, and if not, I'm sure I'll hear from Magic Mike shortly when he hears this. Second, throughout this medium, we've been beset with logistical issues and illnesses that have affected who's appeared on the podcast. As a result, neither Donna Cryer nor Quentin Anstey, both of whom were supposed to be part of these recordings, were able to attend. Donna had a problem flying into town and then a late-breaking conflict she hadn't anticipated. Quentin was invited by Stephen to take a ski lesson tomorrow and then was unable to join us this morning. So still, we've had some great conversations and content to share. The first part of today's episode, Scott Friedman and I separately described the content of the meeting as being equivalent to drinking out of a fire hose. I believe we've succeeded in bringing some of that fire hose energy to you, along with some really exciting information and challenging questions. Today's first conversation includes Jörn, Louise, and Scott Friedman and Rachel Zayas and focuses on sessions 6 and 7 of the meeting, which includes new information on an array of clinical issues and considerations, along with a discussion of the ongoing nomenclature process. Our second conversation includes Jörn, Louise, and me discussing highlights of the two sessions late yesterday, the Potpourri and the regulatory Fireside Chat, which actually wound up talking about payers as much as regulatory at some level. The final session of today's episode is the HistoIndex sponsored conversation between Dean Tai, Jörn, and me discussing a poster that Jörn and Dean presented at this meeting. The poster looked at how HistoIndex's Q fibrosis and Q steatosis processes can clarify the effect of drug therapy on different zonal regions of the liver, and specifically to see differences in response between fibrosis progressors and regressors at a tremendous level of granularity and statistical clarity. We discussed the research and what it implies for drug evaluation, combination therapy, and an underlying understanding of disease. Very cool stuff. I love this conversation. I hope you will as well. The final episode of our coverage, episode 3, will post Wednesday evening and will include a diverse set of stakeholders to consider what we've just learned from a range of different perspectives. I'll have more on who those folks are in the next day or two. We'll be posting that on LinkedIn and our website. So with that, let's start today's podcast. And with that, why don't we kick into our first conversation of episode 2? This conversation focuses on the Saturday morning session, although in some meaningful way, Saturday morning spilled out of Friday afternoon and that session as well. So I expect we're going to cover a little bit of both. We've got a fantastic cast of characters with us. Jörn is back. Hey, Jörn.
Hey, Roger.
This time Jörn showed up without a ski helmet on, which is, I think, probably a step in the right direction.
I left it in the ski locker.
I think that's probably a better idea. And then we have Scott Friedman with us. Hi, Scott. How are you today?
Hey, Roger. Good to see you.
Good to see you as always. Rachel Zayas. Hey, Rachel. How are you?
I'm doing great. Enjoying Salt Lake City and the conference.
And I know Rachel got to ski yesterday. I'm so jealous of everybody who's gotten to ski because I'm told it was fantastic. And then we have Louise Campbell with us, although not at this moment because she's trying to get some of her technology worked out, so she will pop back in at some point. But in the interest of time and everybody's afternoons, why don't we get going? This has been, I think, amazingly, Scott used the word intense. I kind of feel like you're perpetually drinking from a fire hose in this meeting. But what I would like each of you to do at the beginning is see if you can isolate one thought, one moment, one concept, one intriguing thing you heard this morning that was particularly a sit up and take notice kind of thing. Brave one, go first.
Well, maybe I'll jump in. The 800-pound friendly gorilla here is, of course, the Madrigal news, which I would say casts, rather than a pall, it casts an umbra of sunlight around everything related to the NASH-TAG. So suddenly everything, just like I have a joke, everything tastes better at the beach. Everything at the NASH-TAG suddenly becomes more important because this is going to be moving into patients as an approved drug unless there's something completely unexpected. So it means everything we're talking about really has to accelerate. So, among those, tremendous progress in the non-invasive markers, greater identification of correlates with improvement, particularly in the FGF21, increasing coalescence around study design and why they're important, and ultimately, the prospect of biopsy-free future, albeit perhaps outside of clinical trials, and a range of different drugs. Many, many questions unsolved. I'm happy to get onto that, but quick take.
Okay. And for 1 minute, that was pretty amazing. That was about as intense as the meeting was. Well done.
Well, it is, and I use the same analogy, drinking from a fire hose, I think, when Rachel and I were talking.
Yeah, I really do have to mimic what Dr. Friedman just outlined, where I don't think there's a single person in this room or at this conference that has not been affected by the Madrigal positive readout just a few weeks ago. So just the narrative has changed. It's been a great focus of the conference, and it's going to usher us into this new year with just a really different perspective. Other things which we can dive deeper into later, nomenclature by Dr. Ranella. There were some really interesting points there. Discussions around combination therapy and what that looks like and what's most important there is really interesting. And last but not least, some other talks that we'll go into later. So those are the big ones for me.
I think I gave part of my thinking this morning already, and I think I'd like to echo Rachel and Scott on the positive energy that's here. The room is packed. It's my first in-person attendance. I don't have a good comparison, but it feels there's a lot of things going on. And the organizers really try to address the important aspects, from NITs. There was some clinical trial data presented now as a distinguished abstracts, which was very interesting and breaks in and adds to the biomarker discussion that was followed by that. And as such, I think it's a rounded up, very well composed program, and I enjoyed it tremendously.
Louise, question on the floor is one thing you heard that, although that's not exactly the question people answer, one thing you heard that you found particularly gobsmacking or fascinating or changing your vision of how the world comes together?
I think for me this morning, it was the previously unpublished efruxifermin data with looking at the Harmony phase 2 FAST scores and actually looking at that. That shows you that you could put a drug into a primary care area for me and use a real world point of care device to correlate with the outcomes of somebody going on to treatment in the future in a primary care area. Now, I know they presented a lot of other data, but this was just one thing that we've not seen before. So it was new evidence evidence that's to be published in the future, but you were able to see the complete pathway on that line. And if you can do that with resmetirom, obeticholic acid, it becomes a manageable disease in primary care, which is what we've wanted for the majority of people with fatty liver. So I think that for me was a potential game changer, several years coming, but very important data that was released.
Yeah, as apropos of that was yesterday, but Mike Charlton presented a stunning statistic that only 3% of patients with fatty liver disease are actually being seen by gastroenterologists, hepatologists, 97% in the primary care, internal medicine, diabetology realms.
I noted that number, Scott, and I wrote it down too. I didn't write as many notes as you did, but that number I noted down. And it's really up to us in the field now to use those NITs. I said today, I think we have all the NITs we need to identify the patients and support these primary care physicians and referring the real ones that need. So I think that's a big number. For me, that was also big news.
Yeah, and there was a great talk yesterday, I guess, from William Alazawi, who is defining what care pathways are, how they work, and what they're good for. And I thought that was helpful. And then a very interesting brief presentation this morning by folks from Siemens who tested out 4 different models of different sequences of non-invasive tests that yielded either the highest predictive value of fibrosis or the lowest cost. So clearly how we translate these things to primary care and internal medicine is front and center.
Yeah, so we don't talk about this a lot on this podcast, but one of my fascinations forever has been systems theory and complexity. And I've always said that I'm a big fan of complexity and I hate complication. People don't see the difference, but complication is a lot of data points you can't make sense out of. And complexity is finding the through line. And what it kind of feels like I'm watching, at least to me, is finding a whole bunch of 2 through lines that matter about NITs. One to NITs in clinical trial and another to NITs in practice. And they're not going to be the same through line. They're not going to be used the same way, but they're both pivotal. Because if you don't have one, you can't keep developing better drugs. And if you don't have the other, you can't get them used right. But it almost feels like both those things are emerging here in parallel. And I find that, I'm going to use the word thrilling, which is not a word I use a ton. I find that thrilling because then I start to understand how this whole thing can come together. All right, Fagan's nomogram, which I'd never seen before, completely knocked me over yesterday. And it wasn't the only thing, but it was the first moment where I said, boy, this could get really clear really fast. So with that, I think we're all talking about the energy, the enthusiasm, and the big picture, which is 1 part drugs, but 1 or more parts NITs and everything else we're learning around the disease. Scott, you do this so well. I'm just going to ask you, take a couple of minutes and at a high level, what are you seeing that you think is most pivotal and how do you see it coming together?
Well, there are a couple of things. First of all, now that we have a drug that's going to meet both primary endpoints and is nearing highly likely approval, then we have to ask, number one, why did it work? Was it just a reduction in liver fat? Are there mechanisms unique to this? Because we know that not every patient who has reduced liver fat has a benefit in NASH, although more do than not. So dig down a little bit deeper in understanding what distinguishes the responders from the non-responders in this trial, how much of that is translatable to other mechanisms of action. This is the first time I had heard, and it's been very important to me, is what do we do with the patients who don't respond? Remember the Madrigal trial, 26% at the higher dose had a fibrosis benefit. That left 74% of patients without. What's different about those? How are we going to manage those? And when this drug is being given in clinical practice, how are providers going to know their drug isn't working? So this is the first time I've heard really emphasis on tracking the disease in patients on therapy to assess response, because patients don't want to be on a drug that isn't working for them. They want something that is. And of course, payers aren't going to pay for drugs that aren't working. So you got 75% roughly of Madrigal treated patients in an ideal situation of a placebo-controlled clinical trial. 75% roughly are not responding. We need to learn more about them, how to identify them early and in practice, how to get them off the drug on onto something that might be more beneficial, and how do we decide what that second drug might be.
This is such an important statement, Scott. And the one thing that I would say is, the way we define response today is the improvement of fibrosis by 1 stage on liver biopsy. And that's a regulatory endpoint, but it might not be all the benefit the patient experience. And while it's the one that's linked to a liver outcome that's important, they'll probably, I think they have a pretty robust LDL lowering. You could choose other drugs that probably outperform this. And the time point of the biopsy is always have to be kept in mind. So it then comes to the question, how much money do we spend for this drug? And if they're not showing the histological benefit, are there other benefits they could have? But if it's an important drug, we can't keep them on. I think that's the things that come to my mind.
So I think the exciting thing is the conversation has changed. We finally have a therapeutic with a clear pipeline forward. But a conversation that I believe Vlad Ratsu, a talk that he gave yesterday, is what is the best approach forward with a combinational therapy? Because as Dr. Friedman just outlined, 75% of patients are not responding. So there's a lot of room for improvement here. So do we have a simultaneous treatment with another therapeutic in a different pathway? Do we have a sequential treatment treatment with a second therapy, or is it like a booster? And how do we answer these questions? A point of discussion that has come up in this conference as well as previous conferences is what's the best timeline to look at the benefits to patients and the primary endpoints? Are we not giving patients enough time? Should they be in 2 to 3 year trials? And what does that look like? So I think that there are a lot of questions now being asked that we don't have the answers to, but the discussion has started. So that's the first point. And I find that really interesting and compelling because there's a lot of room for growth here, just from this perspective.
I think I'd just echo that. And I think we've seen some data this morning that looked at using AI to look at non-responders and responders in biopsy samples. The excitement about the discussion this morning is this moving it beyond the outcomes for clinical trials in the real world. And I think Naeem opened up with his slide going biopsy is dead in real world care, but it's not dead in outcomes for trials and the measurements for trials. So I think the evidence this morning is fairly strong and compelling on not only being able to predict therapeutic response, but to be able to predict outcomes depending on that, on some of the NITs. But we'll gather more evidence as the trials go. I echo what everybody said. It's a game changer, but we do need to address, and we discussed it briefly in yesterday's recording, the other 75% of people who will be targeted with something else or a second therapy. And there was some very good data from yesterday on the semaglutide, Gilead combinations that they use. I think, yes, they're in trial, they're early, but we're moving there, and that's really exciting.
Well, I'll make an editorial comment about combinations, and I know I've said this in a prior podcast. The approach currently for combinations is frankly anti-intellectual, or I don't want to go so far, but it's almost irrational because it's driven by which 2 drugs a company has or has access to, some vague notion that one is more anti-inflammatory and another is more antifibrotic, another is more anti-steatotic, and hoping, basically putting your finger in the air and hoping that the wind blows in the right direction and you see a benefit. And that clearly is not working. There are so many wonderful systems for doing a medium and high throughput analysis of not just efficacy of drugs, but molecular mechanisms. And I'm talking about organoid cultures. There was one presentation yesterday. There's very mature work being done by Takebe in Cincinnati and by CROs like Insphero and others that you could line up different drugs. You can interrogate the genes and how they're affected. You could look for synergies and you could screen dozens and dozens of combinations at a different dose range. And then even if they're established drug, and then use that information to test it either in animals or in people. Because just embarking on the 12, 18-month combination trials because the company has access to 2 drugs that are somewhat different is really wasting a lot of energy and time. And it reflects our naivete about the real pathogenesis of this disease. Is it the fat? Is it the inflammation? Is it the ballooning? Is it a little bit of everything? And hopefully those will start to clarify as we ask the kind of questions I posed earlier of, how does resmetirom work and why doesn't it work?
And it wastes a lot of money too. And I think the field was still driven by some companies that tended to take that as an approach, trying to score bullseye. But I agree with you, Scott. It should be evidenced and scientific rationale should be strong before you do that because it's much more complexer. And then...
So, Jörn, I'm not sure where this fits into the conversation, and I'm counting on you to pull me back if I get too far in. But at the end of this episode is a conversation sponsored by HistoIndex that Jörn and I had a couple of weeks ago with Dean Tai, the Chief Scientific Officer there, about a poster that Jörn has here, and Naeem showed some of those slides this morning. So one of the questions that fascinates me, and I'm going to come back around to that in a sec, is if OCA works with 25 or 30% of patients and resmetirom works with 25 or 30% of patients, are they the same patients? If they are the same patients, then, Scott, that would scare the stuffing out of me because that would say that it's a much more amorphous world than we've realized. Yet you would think if the world was logical that they wouldn't work with the same patients or they wouldn't work in exactly the same way.
Well, there has been some combination with another FXR that didn't show particular benefit with silofexor, I think, or was it tropifexor, or both. If I were a betting man, Roger, I'd bet that it was the same patients or there'd be large overlap more than totally distinct groups that are responsive. Because if it's the latter, then you would think that combination therapy should capture more targets, but I'm guessing that's not going to be the case.
The thing we have to be careful is they're not head-to-head studies, Roger. And again, for example, the Madrigal program enrolled with a number of metabolic risk factors, which wasn't done with the same stringency in other clinical trials. So I think there's still different trial populations. Nonetheless, the type of AI histological assessment could bring us a little closer to the questions that Scott raised, at the level of the liver, how does that actually work? Which patients are responding and not, which are showing which changes. And I think that's where the AI, and that's what Naeem mentioned in his talks, where the strength of that technology comes in.
Yeah, I think that's right. I mean, the one thing the histo technology gives us is the ability to pinpoint where in the liver are responders and non-responders, or progressors and regressors doing differently with literally geographically, where is it showing up, which would would be one way of looking at it, not hardly the only one.
So I have to ask this to Scott. Can a stellate cell be hypothyroidism?
Yeah, so there are old studies that suggest that stellate cells are responsive to thyroid hormone. I can give you those references offline, but there's been enough evidence to convince me that thyroid hormone activity or thyroid axis activity has direct effects on fibrogenesis, for better or worse.
And that's interesting. That's where it closes, right? Because we're not talking systemic thyroid hormone. We had this morning. It's something in the liver, and it might be an effect on stellate cells and not just lipids, and that we're not seeing yet.
I don't remember, it was Michael this morning. I think it was Mike Charlton who said that, which is true, that NASH is kind of a liver-wide hypothyroid state. That includes effects on stellate cells and fibrosis. So it's not just mediated through changes in hepatocytes by any means.
So I might have pulled us away a little bit, which I didn't mean to do. But how do we start? I mean, these are the issues we need to tackle, right? For drugs to become commercially viable, we can't say, trust me, 10 or 15 bucks a day for 18 months and 25% of the time you'll get a good result. How do you see, based on what you see today and otherwise, what are we learning about how quickly we can improve that process and how we might improve it?
If I comment on Jörn Rotman's talk this morning, it's not going to be genetics. He did a nice way to lay out that, FIB4 outperforms any genetic aspects we have in terms of trial enrichment. He well stressed the fascinating pipeline of targeting genes in a therapeutic context, but as a diagnostic tool, it's probably not genes. And that's my comment here.
Yeah, I thought that was a pretty effective takedown. I agree with you.
Roger, to your question, one other thing I learned that I hadn't heard at all was that, at least in the FGF21 trials, responders have a higher level or a higher increase in adiponectin, which is, of course, thought to be protective or beneficial hormone. So that's a window into how we might anticipate these trials. If the FGF21 trials define the minimal level of increase in adiponectin after a certain time of treatment, maybe 3 months or something, if the patients don't elevate their adiponectin sufficiently, and we know that correlates with lack of response, that would be an ideal model for that drug or target where you have a biomarker that indicates at least pharmacodynamic engagement, if not benefit. And for those who fail to increase their adiponectin, it could mean that, stop the drug early rather than later and not wait for more general NITs.
If I'm right, it's not only that drug, though. If I recall correctly, Inventiva produced data on lanifibranor at AASLD. In fact, we had a conversation, Jörn and I, with Michael Corman about that, and an interview on the podcast last fall that showed fundamentally the same thing. And at that point, nobody had shown it yet, right?
Can I ask on that point, is there a sex-related response to adiponectin? The data that Rohit Lumber showed, 75% of the trial population on the pegazofermin were female. The average age was 58, so they are all postmenopausal women, and it massively would change the dynamic of the study. So I didn't get to hear some of the early stuff on the adiponectin, but I just wondered whether there is a sex-related response depending on whether or not you're pre or post-menopausal. And Daniel Huang yesterday presented data. Now, his population were 48 and they were predominantly male. So the risk factor of male-female being 1 and 0, if you were female, you had no risk. Actually, I'd certainly argue it was the age demographic, but for adiponectin, I wasn't sure about a sex-related response.
It's a great question. I didn't hear anything to separate out the gender responses.
I don't recall, and I haven't thought to ask. So thanks, Louise.
I'm sure that if they haven't, they certainly can, Madrigal can certainly look at whether serum adiponectin was a response marker in their population as well, because that would be terrific. If it's a mechanism-agnostic indication of response to a NASH therapy, that becomes a very powerful way to address the concern about drugs that aren't working and how long to treat.
That's true. That would be huge.
Yeah.
I don't think it's an easy assay, Scott, right? You got to be careful what you measure. Is it the full protein or at parts?
Yeah, I don't know the details, but you're certainly right that you need to know what you're measuring, and it needs to be standardized if it turns out to be useful. There are a couple other minor wows, Roger, I can do so if you'd like. Well, one was a nice talk by Brian Lee at USC, who's become an expert in detecting alcohol monitoring, and he gave a really thoughtful talk about how surreptitious or unmeasured alcohol use confounds or may confound the interpretation and efficacy of drugs used for NASH. That was, to me, a real eye-opener, and he raised the question of whether patients should be monitored. Becky Taub said that they had been monitoring with the polyethylene, I don't remember, PEth is the short term. And then the data were all over the map, so it didn't sound like it was useful in her hands. But nonetheless, he made I think a compelling point that we haven't really addressed this. We haven't standardized even what a normal drink looks like. And he showed some data from Austria from a number of years ago that suggested that actually when you monitor patients, I think it was with patients with cirrhosis, 70% or more had, based on a hair test for ethyl glucuronide, 70% had biochemical evidence of alcohol use, even though they initially denied it. So that's a real confounder that, I think think we all would agree that any amount of alcohol is going to make things worse, and it's certainly going to confound the interpretation and maybe the efficacy of drugs, although hopefully, as Vlad said, randomization would at least address that somewhat. In other words, you have the same amount of alcohol used in both treatment and placebo groups.
Oh, yeah, so therefore, right, you have a comparatively comparable error. Well, the other argument you hear about that, though, is that if the patient population you're going to be dealing with the drugs is a patient population that drinks, then is limiting trials only to people who consume no alcohol, provably consume no alcohol? Is that a realistic snapshot of the population you're going to deal with? It's a little bit like the thought that goes 14% of the patients in the Maestro trials are already on GLP-1s,
right,
which at least to some degree ameliorates the question that goes, well, what happens if you put a GLP-1 on top of this?
One other minor wow was a charming talk by a radiologist, Claude Serlin, who's been in the liver imaging space for a long time. Really was shocking to me that this whole concept of liver volume assessment is based on the thinnest of evidence in a single study. And it does raise the broader question of, are changes in liver volume telling us something? Does it reflect, or if there is or isn't a decrease in volume, is that a predictor of response to therapy? And if the volume is changing, why is it changing? So it introduced the need for technical improvement, which undoubtedly will come, but also introduced the concept of overall organ size or volume as a reflection of either disease stage or response to treatment.
Just to follow up on that point specifically, one thing that really stood out to me from that talk was that he said in the last 100 years, there have only been 2 papers that assess the reproducibility and repeatability of liver volume measurements. And in that assessment, it was only in 10 patients. So we need to do better and we need to do more, because if this is a non-invasive methodology to indicate biological plausibility or disease status, this is a really simple method. So there's a wealth of opportunity going forward to conduct these studies. So
yeah, I was just going to add to that. Bariatric surgery, they put them on a fat reduction size diet before they go into theatre to reduce the size of the liver so they can do bariatric surgery. So they've been doing it for years, but none of the studies that he showed accessed or had any data in relation to the size of the liver pre and post the fat reduction diet. And in fact, knowing a couple of people who've done that, it's the first time that liver size and the liver involvement is really mentioned in the bariatric process as to how they could have got there. So I think there is a wealth of data. We could probably mine it from that because they'll have all had their scans pre and post. But what amazed me was the majority of the studies, it was all hand-drawn and done by hand to measure size, which I thought his was fascinating and really entertaining.
So, yes, agreed with all that. Duly noted, though, that, well, Lars Johansson came on this podcast over a year ago now, and talked about spleen volume, and Stephen talked about spleen volume in one of his presentations. So I was kind of struck that Claude did not, at least from the part that I heard, because I was solving 5 problems at once during his talk, make much reference to spleen volume or other organ volume in this context.
Well, if I understood correctly, it's premature to make comments about spleen volume because if I understood Claude correctly, the technology is not standardized and reproducible yet. So the jury is out as far as did everybody get that impression?
Yeah, and he said that really like the first generation assessments, it's called the CNN convolution neural networks, came out in 2019. They're used for CT scans, MRIs, and they were used to trace liver and spleen volume, but 2019 was not long ago. So this is really just first generation.
You should use CT and all the same machine on the same patient each time to even get anywhere close.
Yeah, that was pretty striking. Although that wasn't news. I mean, anybody who's ever been a cancer patient knows that if you go get a scan done in 2 different places on 2 different machines, you get 2 different results, which is pretty good for scaring the crap out of you sometimes, but that's no practical value. And your oncologist says, hey, don't worry about it. It's a different machine. That's not enough to matter. Said the voice of experience. Where else do we go here? I mean,
Rachel mentioned her interest in the nomenclature discussion. I'd love to hear her thoughts about that.
Yes. So what really stuck out about Dr. Anella's talk was the overlap with historical context of nomenclature. She said that rubella had 8 to 10 different name changes before we finally chose as a scientific community to use rubella. AIDS, of course, in the 80s, there's still a stigma with this epidemic. And then just of recent is COVID and the societal impact of the words and the nomenclatures we use. They truly define a field in the greater society as well. So those points really stuck out to me, and I can go further into a few things there, but it warrants a further discussion. I'm really interested to see what comes out of the studies that they're conducting conducting right now. They're in the fourth process of the assessments that they're going through. So I'm going to watch that very specifically to see what's coming out.
Yeah, it's a very stringent Delphi process, and it has a lot of stakeholders. Not everybody agrees. And of course, there is it's a little bit painful process moving forward, I think is my comment also for them. And they're doing a great job. But overall, in clinical trials, we're using histology to define that. And that's not going to change now, even by calling it differently.
Yeah, I don't know. Will it be flash tag or something else? I don't know. Fatty liver. Anyway, I'll make one other point, which is I was skeptical about the name change. And frankly, I thought the timing was pretty bad. But in a sense, it was an upstart effort to change it to MAFLD, metabolic associated, which has some just, rationale. But it was a rushed process, mostly out of Asia and Australia, and EASL and ASLD, from a political perspective, did a really good job of trying to be highly inclusive and developing a rigorous process that has really impressed me. And so it was disappointing. Jörn was tactful. I'll be a little less tactful. After all of this effort and inclusiveness, folks from Asia have decided they're just going ahead with their name and to heck with the rest of you guys. And that's very disappointing to me. And it's so unusual for the community culture around hepatology. We just don't do stuff like that. And I'm disappointed, but we'll see how the process plays out.
If I understood them, Maru said they did something similar in PBC.
Yeah.
Okay. So it could be them. So Jeff McIntyre's never been on this podcast with an opportunity to talk about this conference, but he makes one point that I think is worth sharing. That's a critique of the process as it was set up. I have an answer to it today, and we'll try to get one. While you need a certain level of consensus, the consensus is in a group that is overwhelmingly made up of clinical researchers. So Jeff, as patient advocate, says, the famous Donna Cryer line, which she didn't originate but is brought to this disease, is nothing about us without us. And his point was that if 80 or 90% of the clinical researchers want to go in a specific direction, then what the patient advocates want to do, even if they were unanimous, isn't going to matter.
But I do think there are patient advocates that have been totally engaged in this process, Roger.
I think that's right. And that is the flip side of the question. And by the way, they've disagreed, for those of us who missed Donna Cryer and Robert Mitchell-Thane on the stage at AASLD, which was quite a show in its own right. So I think that's right. It's not that they've not been taken into account. It's a question that goes, are there priorities?
Can I be slightly controversial on that, though? When I looked at when Mary put up all of the stuff, I didn't notice any patient advocate who wasn't Caucasian or Black. And we're talking about Asia Pacific and Australasia going their own way. But I didn't notice those stakeholders in the nomenclature process from a patient advocacy. And I may have just missed that. So I think it was important just to go back and on that point. So maybe they don't feel that they're being heard at the table, which is why they are going their own way. They started the process themselves. So I just wanted to throw that into the ring a little bit, spending time over there.
That's fair. And I think there's another difference that interests me. The thing I heard from Maru this morning that struck me was that there is no consensus around the idea that changing the definition of the disease will have an impact on clinical trial work done to date, which I've thought up until now, I've believed and continue to believe is the most effective critique, not against the name change, because you can separate the name change and the disease description, but any redefinition of disease. The people who are most integrally involved in drug development are concerned that it will damage a lot of the work. And now I'm not only talking researchers, but even more than this, the sponsors, the drug and the device companies, are concerned that a change in the definition of disease might throw out a whole bunch of earlier research and slow progress. I don't know how that will work, but I was struck by the idea that didn't quite seem to get to consensus, right? It was 60 or 65% right below the threshold. I don't know what to make of that.
Another little mini wow. Rohit Lumba gave a great talk about the evolving combinations of NITs, the MEFEB, the MAS score, et cetera. He mentioned that the granddaddy of them all, the gold standard of screening, was the Framingham heart study, and their ORAC was somewhere in the range of 0.6. And here we're beating ourselves up according to him, we're beating ourselves up and self-critical about ORACs that are 0.8, 0.85. So I thought that was a very interesting perspective. Maybe the bar is set higher just because it's 30, 40 years later, or maybe we're just a more self-critical lot, or maybe the payers and investors and companies are demanding more. But I thought it was an interesting contrast.
Yeah, I think the bar is set higher, frankly. One of the things I've talked about a bunch, Scott, Premarin, right, which got approved in 1939, and they never got a generic out, even when it was a $2 billion drug, because the biodistribution was so erratic that you couldn't mimic anything that erratic and consistently get within the 15% of generic needed to get. By the same token, I don't think anybody would ever accept the biopsy as a gold standard today because it's erratic. And one of the points that's made frequently now is that we're progressing past trying to match an erratic target to going straight after outcomes. So I just think the standards used to be lower.
What was it that Quentin Jonathan says, perfection is the prevention of good. That's the phrase. Maybe we're aiming for perfection. I thought that was a really interesting comment also.
There's a comment that Mazen made last fall, and again at this meeting, and Lauren Costera as well, that I picked up on. I mentioned it this morning. I think this idea, apropos of perfect being the enemy of the good, the most important thing for practical use of all these tests may be indeterminate zone. Because if you get a really good positive predictive value, a really good negative predictive value, and to do that, you've got to throw out half of patients because they're indeterminate. That's got minimal predictive value in the real world, because half the time, right? Every coin toss, half the time you shrug your shoulders and say, I don't know what I got. So the ability to get indeterminate zone down seems to me to be a real compelling advantage. And certainly when we think about how to use the sort of practical management of patients, low indeterminate zone is going to be the winner, because that's what will allow frontline treaters to treat without thinking about it all that much. So every time I hear that point, it makes more sense to me. And it really kind of clicked in yesterday afternoon.
Let me add on some angles based on the presentations we had with regards to prediction of treatment outcome given by Stephen, and the outcomes data NITs Rohit Loomba gave that talk. Stephen was propagating the combined biomarkers a little bit in terms of treatment outcome. But then in the discussion, I heard him say, maybe ALT is the single most important one. In my thinking, somebody beat me to the microphone, was if we use compound biomarkers that use multiple tests to combine, and it will always be important to see what actually changes and drives that change in the compound. So you have to always report the single biomarkers too, I think, for us to understand it, because it's going to also be different depending on the MOA of the drug. And if you then start comparing multiple mechanisms of action, looking at a compound readout, this is going to be at least something we have to think about.
It makes tremendous sense to me. We're getting to the end of our time, and I know people have places they need to go. So why don't we just wrap up? Okay, we've talked about a bunch of stuff. I'm going to ask a similar question a different way and see if we get any different answers. The one thing you've heard this morning or yesterday afternoon, really, that you believe will have the greatest impact on how this disease is treated 3 years from now. And the answer can't be we're going to get drugs approved, because that's too easy.
I would say we're going to get one or two combination NITs that show correlation with outcomes and supplant biopsy within 5 years.
Okay. Because we're on audio, I'll say everybody's head's nodding. So, Scott, you just took what appears to have been the low-lying fruit after I took the lowest-lying fruit.
And that's usually the case, right? You open mouth, insert foot. But
No. Low-lying fruit simply means you grabbed the thing that was the most important and obvious. I wouldn't say open mouth.
I was going to say something on genetics and biomarkers, but I should leave that to Rachel.
Yeah, I think that it's important to discern the difference between heritable genetics and epigenetics, because the two are often conflated as the same term, and they're not, which is something I can go into at another time. But I really think that the biggest point taken away today is that 97% of patients are not getting to gastroenterologists and hepatologists in appropriate time. So just to echo what Dr. Friedman just said, is the use and utility of non-invasive biomarkers. I'm excited to see the changes and the opportunities present there.
I was probably going to finish with what I started with, is the fact that we're going to be able to use non-invasive technologies either in combination to track the response to medication or to any treatment, because I think if you can use them in medications, you can then use them in lifestyle management. And I think that becomes a bigger part of where we should be going with lifestyle, and keeping those who don't need medication off medication, because we can use those NITs to predict those patients as well as those within clinical trials on drugs.
Yeah, it's a great point. It's effectively a motivator to keep people from advancing to the point where they need drugs. And we do that with diabetes, right? Someone has an elevated hemoglobin A1C. We say, look, you have prediabetes. This is a wake-up call, and hopefully we can use the same kind of approach.
I think that approach winds up becoming important from a bunch of directions, right? I mean, the one that Louise points out is one, Scott, the one you pointed out is a second. The point that's been in this conversation, that payers, patients, and providers are not going to live indefinitely in a world where you got to give a patient a drug for 18 months to find out that 75% of them have gotten no benefit from it. This is all about the same stuff. It's all about, can we get smarter, faster, how to use NITs to figure out therapeutic pathways. And Scott, I think you're right. I think what we've, like I said, I'm starting to see the through line here, even though I couldn't tell you exactly how it goes, but you can see it coming. And I think that's huge and gratifying. Well, let me thank everybody for joining this talk, which has had the attendee list and the time changed 4 times in the last 24 hours. Thanks everybody for your flexibility. And we will be back with another conversation that'll be the second half of this episode that's taking place tomorrow morning. Scott, Jörn, Rachel, Louise, thank you. In fact, Scott, thanks and talk soon. Rachel, Louise, Jörn, I'll see all you guys tomorrow morning for the next round. Thank you, everybody. And enjoy and ski on, folks. Bye-bye.
For our next conversation, Jörn, Louise and Roger discuss the final 2 sessions of NASH-TAG 2023, the Potpourri session and the regulatory Fireside Chat.
So this is our last real-time conversation of NASH-TAG 2023. We will have a wrap-up episode that we'll post on Wednesday evening. But consistent with the trend of our coverage of this meeting, which has been, we've had constantly changing casts of characters, it turns out that both Rachel and Quentin have fallen prey to illness. So all we have with us this morning are Louise and Jörn and me, which is kind of how we started the preview of all this back in December. Jörn, how are you this morning? I guess it is morning. It's like 6:30 in the morning for Jörn, and he's got to catch a flight in an hour, or catch a car to a flight in an hour. How are you this morning?
I'm fine, thank you. I'm full of impressions and good vibes of really a great meeting at a great location. We did some socializing last night too, so it's a round package. I'm a little tired, but I have time at hands today going back.
It sounds like to me like you're in perfect condition to get on a 10.5-hour flight in Denver and just, fall apart.
That's about right. I would have not minded going for another 2 days of skiing. I have to say I got in some skiing every day. I had great ski buddies, you'd call them. I'm not giving away their names, but it was really, in case you're listening, it was a pleasure, and it was really very joyful and rewarding to be here. I mean, the snow is great, and the science was great. It was good to exchange.
So, Jörn, how strong a skier are you? What kinds of slopes do you do?
I would say I can ski well. I'm not the prettiest skier. I have my own technique, but I plow down almost everything.
Okay, because next year, assuming I make it out there, I'll ski with you. I don't do diamonds much anymore. Not because I couldn't, but because you get old enough that the cost of falling doesn't seem like it's worth the price of speeding.
No, you're right. You want to get healthy off that mountain, but I couldn't get the smile on my face. It was sun, it was snow, it was really a great day.
Okay, so next year we'll ski together. I think that's something to look forward to. Maybe, in fact, we'll Shanghai. Louise, do you ski?
Oh, yeah, I ski.
Okay, so next year Louise is going to have to come join us.
Well, I'm trying to join you this year. It's just a bit too early in this season, post-Christmas. But yeah, maybe a flight from Australia for a warm Christmas and then a bit of Utah, Deer Valley snow.
Well, all you have to do is go the other way. If you're coming from Australia, just go through Hawaii, right?
Yeah, so mark your calendars. I think it's going to be the same weekend.
It's the same weekend every year. 250 people, packed room, high levels of intensity. One of the things I look forward to hearing about this morning, but we'll get this in soon, was Quentin and Phil on the slopes yesterday. Quentin and I had an email exchange about it yesterday morning. He was highly concerned in advance, but my impression is that he made it through more or less in one piece.
They did. I saw some pictures too, and again, these gentlemen did well, and I think they're hooked to skiing by now.
Stephen actually wanted to see if he could get somebody to take a video of it, but
I think they self-documented it. They'll have to decide what will be shareable.
Okay, that's fine. And then there was last night. Louise had an experience I know well yesterday afternoon, which is she watched Liverpool play a soccer match where they did what we call the completely Spursy thing, which is gave up a draw in a match that they desperately didn't want to draw. In fact, they probably would have preferred to lose compared to draw. So therefore they drew and looked really uninspired in the process and got very lucky on not getting a late goal against them. We were commiserating before the call because this is the life of a Tottenham fan. So she got to feel what it's like on our side. And with that, let's dive in. We have about 40 minutes scheduled this morning. So let's dive in and talk a little bit about the meeting yesterday. Jörn, I'm going to let you do a lot of driving. Right? There were 2 sessions. There was the Potpourri session, which was a collection of different kinds of papers. And Scott had been on with us as part of the run-up to this, talking a little bit about his, although, as he said correctly, the way he chose to present it, I thought was really pretty cool.
It was. The movie selection spoke to his person. He really did it in a memorable way, being able to relate to the different papers, the octopussy with the endotangled fibrosis, stellate cells and hepatocytes. And they were actually nicely shown that. So, it teaches us a lot of things in particular. And that was one of the discussions we might get to in the Fireside Chat. It's important to understand that not every drug is going to work in cirrhotics because it's working in non-cirrhotic NASH. The basis for that, I think Scott showed a paper, that was the one with the octopussy coming out of his lab, is the structural changes in the liver. Just so much, we know that, but they were able to picture that at the cellular level, are so pronounced that even if your drug has an action in F3, it will not automatically in F4.
So everyone understands, because the fact that he chose octopussy as one of his movies, he made interesting choices. He took, if you remember, we was on last month, he said he was going to talk about 5 different papers, and he took each paper and tied it to a film. But the film choices were pretty diverse. I mean, they went from Octopussy, which was a James Bond movie from the 70s, to the greatest beer run ever, or whatever the heck that's called, called, which is a movie that was on for about 15 minutes last year, which he tied to, what is it, autonomic brewer syndrome, or what is that called? The idea that some people's gastric systems produce alcohol on their own. I once had a woman working for me who had that problem. I was convinced, in fact, it got to a point where we couldn't keep her. And she swore she wasn't drinking. This was back in the 90s, and nobody knew about this stuff. And she explained this was the problem she had. And passed away in her early 60s of liver disease. But it was true. She'd come to work every morning smelling like she had alcohol on her breath, and there were days where her behavior would be absolutely tipsy, and she swore she never drank. So I've actually seen that firsthand. And I'm trying to remember what the other ones were. I mean, a couple of them were classic old movies. It was a pretty brilliant presentation. And he did it in the context of the Sundance Film Festival and films that might appear at Sundance.
So it was great. The second part in that session was they had two distinguished awards, and then, of course, Naga Chalasani presenting DILI, which is an important aspect, in drug development. And he came up with a rule of 2 and 3, highlighting that the dose and the degree of hepatic metabolism is crucial. And, it costs. A few drug development programs were actually discontinued based on that. So that's always important to consider when you're in drug development, obviously. But I really enjoyed the talk on endoscopic endobariatric management of liver disease. The faculty's name was Sik Jirapinho, and that was probably not the right way to say it.
As it was being pronounced, I was trying to write it down without having the agenda in front of me, and I couldn't get close to it phonetically. So I think that was bold. Go ahead.
Yeah, she's at Brigham's and heads up the endoscopic bariatric suite there. And she was presenting data that they did an impressive amount for single center studies, 120 patients. They're using different kinds of endobariatric therapy. The approved Obera balloon is one of them, but there's also endoscopic suturing techniques that are quite advanced. Having done endoscopies, you can tell that she was really skilled at that type of procedure. Different suturing devices you can use, and the net effect with weight loss and reduction of non-invasive tests was impressive. Now, there are two things that stood out. One, I think she highlighted that she does use this in combination. You could tell they thought about the way they combine it with weight loss, anti-obesity medications. The example she gave was GLP-1 treatment, hitting the patient at that time with a slope of weight loss just typically between 8 to 12 weeks after, let's say, endoscopic balloon placement comes down, adding on a medical therapy, making this a true combination and getting the patient into a level that is only achieved by endoscopic surgery otherwise. So I thought that net effect was quite impressive, and kudos to them for setting up such a stringent program on weight loss for their patients.
Also, then she was then able to go back and tie it back to the main subject of the meeting, right? What it implied in terms of liver disease. And I agree with you. I believe that one of the things that I'm seeing as a meta trend over the last 6 to 8 months, really since Splendor, but not only because, which is over a year ago now, but not only because of Splendor, is an increasing focus on the role of bariatric surgery in liver disease, not just in weight loss and not even just in metabolic syndrome, but starting with Splendor and the ability to regress fibrosis with successful bariatric surgery, and then the techniques that she was talking about yesterday, as Jörn points out, correct? Same thing struck me. You could do less extreme or less risky surgeries if you had really good technique. You could augment them with GLP-1. You could get a comparable effect with probably a better overall metabolic profile. And if I heard the talk right, Jörn, help me, maybe a little bit less focus on sarcopenia if you're a little more careful on how you do this.
Yeah, so the sarcopenia was a question. They didn't really have an answer up to that. And it's an important thing, we're discussing with all the weight loss medication, or what's the ratio, fat versus muscle loss. In particular, and this was the second aspect that stood out for me from that talk, we're treating cirrhotic patients. So there was a discussion around the degree of portal hypertension that would be suitable to do that. And actually, they did something very neat on top, and they measured portal venous pressure gradients. So the way, or let's say portal hypertension, the way it's normally done is by HVPG. It's the one that's indirect, but there is an endoscopic way to do it, because with endoscopic ultrasound, you can visualize the portal vein and actually hit it directly with a balloon or a needle and take a direct pressure measure. So this is something they did. Again, endoscopic center, they would do these type of things. And it's not that common. In Europe, you have some centers doing it. We started to do it, or we're looking at it, but it's an interesting technology. And something she said is that with balloon placement in patients with portal hypertension, actually the pressure went up. So this is something they wouldn't do. And the second thing is with the suturing techniques, if you have gastric veins that are prominent from the portal hypertension, you'd really not want to go there and stitch it. So they said they're going to do it in patients with esophageal varices, but not with signs of gastric veins in terms of portal hypertension. So again, very interesting. And in that cirrhotic population, obviously the weight loss is a concern. What's the balance of sarcopenia versus non-sarcopenia? Kind of translates to the concepts of dual agonism, GLP-1s. I think it's a little bit different, but net effect, weight loss.
True. And so one of the questions I had watching that, right, is I think I made this comment at the end of yesterday. Somebody on a podcast last month made the statement that most things that you find in clinical trials ultimately make their way into practice. And I was trying to visualize how long it's going to take for some of the techniques that she was sharing to make their way into more general use.
Yeah. So they're there. I think it's clinical practice to offer offer them, but they're, of course, restricted to centers that are focusing on endoscopic bariatric management of obesity. I would say the combination is probably something most centers don't do. And in my personal experience, in particular, somebody who offers either endoscopic surgery or endoscopic bariatric procedures, sometimes patients are left a little bit by themselves, which, of course, the time after the procedure is the most critical one. So by them highlighting the way they did the combination therapy, I had a really good feeling about the intensity they cared for the patients in the post-procedure window.
Agreed. To me, that was one of the surprise talks of the conference. I mean, I listened to that not expecting very much, and I thought it was really fascinating. She was very, very good. I agree with that. And then, so what else was in that session?
2 abstracts.
From Stephen, actually. Was one of them Altimmune?
Yes. So it was the session where he was the moderator and the speaker, and the moderator had to ask the speaker some questions. So it was,
well, that's because the other moderator was Phil, who he had out on the slopes. So with that, Louise, questions or comments before we go on and talk about the Fireside Chat?
I obviously didn't attend those sessions, but I did want to just quickly ask, in the end of bariatric surgery, did they look at the opportunity to find liver disease earlier in the pathway and to use it as once you hit the pathway, let's assess you quite early? Because obviously there's an educational element, there's a location, there's an assessment and getting the patient teed up. Now, we've had the discussion on here before about if you put people out of work, they tend to less engage in that. And we're not going to remove the amount of bariatric procedures, but we might actually be able to use the location of the fatty liver underneath, because it doesn't surprise me. We know it's strongly connected to obesity and fatty liver, but I wonder how much early assessment they were doing rather than waiting for surgery.
Yeah, she was only speaking on the endoscopic sides of things, and she mentioned one case where the surgeon referred a patient based on the presence of cirrhosis when he was prepped for the Roux-en-Y bypass, and I'm not sure that this is an established pathway. We got into a little bit of a discussion around the way it's refinanced in the US, and she said there was some copay for some of her patients, but most are out-of-pocket expenses, and as such, I think it's really referral-based a system without a defined pathway here. It's a decision of patients to go that way and invest the money.
Yeah, it was not inexpensive. I think she said $12,000 to $15,000, but that struck me as less money than I would have expected it to be, frankly. So, I mean, if you put a gun to my head and asked me to take a wild guess, I would have been in the 20s somewhere. But and it would have been a wild guess, trust me, and obviously wrong. But yes, I think that's right.
But I suppose it brings us back to this point of assessing the person, not just the procedure. If we look at, I know renal transplants that have been done in patients with cirrhosis because they never assessed the liver before they transplanted them, things like that. We've got to be more person-centric, not just a procedure. And I think it's been commented on before that, and particularly in primary care, we look for what we're incentivized to look for, not what we actually necessarily should be looking for. That's where healthcare, sometimes for me, doesn't look at the person and all of the opportunities that encounter earlier downstream can make. And we've heard throughout this conference really lots and lots of ways to assess patients and familial lines and this, that. But if we don't use them in the right areas, then all they become is research. And going back to your point about research making it to frontline care, I think the figure was average of 17 years. Now that's a concern because we spend a lot of very heavy investment and real academic studies doing things that may never ever get beyond because we're not joining the dots. And I'd like to see, certainly as a patient advocate and certainly within liver disease say, we need to be joining the dots. We're joining them with endocrinology, we're joining them with cardiology. But I think Michael Chelton's 3% of the population only making it to see a liver physician. Actually, we don't need to necessarily see 100% of that population, but we do need to see a lot more than the 3%, as we know. So just joining dots.
Louise, first of all, that's a place where I think getting drugs approved is going to make a huge difference because up until now, patient advocates were talking about this, right? Up until now, one of the things you hear a lot is doctors saying, well, what's there for me to do anyway? So why do I want to get engaged? But with drugs, then in fact, there'll be a lot more education, and B, you'll then have something that a doctor can do. So getting patients into and through the system, that'll increase. The thing I'm interested about in terms of the U.S. system, right, where you've got case management from insurers on expensive procedures, is over time, will any of this get covered? And if it gets covered, what will the case management process look like? Because right now, unfortunately, case managers too often just look at data as compared to cases, or they don't adequately individualize. Here, one of the things I think that came out of this talk was the need to individualize. We're talking about these kinds of surgeries and endoscopy. So we'll see what happens there. Jörn, any other thoughts, or shall we dive into the fireside chat?
Let's hit the fireside chat. I was a little disappointed it wasn't actually a fireside. I guess I would have have pictured everybody moving out of the room, but that's something, the organizers were asking about improvements and questions, and I actually did see them sitting in nice ear chairs, kind of relaxed. There was no drink with it, but the discussion was great. I mean, it was a great faculty. Donna was on stage, and it was a very good discussion.
Yeah, a lot of perspectives, right? I mean, Donna, Scott Harrison, Amy Articolo representing pharma, and then Rohit moderating, and Stephen, and who am I forgetting about? Vlad, right. So lots of perspectives.
Lots of perspectives and a lot of experience around drug development. And that session really went around the drug development aspects of things. It was open mic, intended for the audience to ask questions after some initial shyness. I think the way it started out was, we need to substitute the histological endpoint as surrogate of improved or possibly improved outcomes with non-invasive tests, NITs. And I think this is where the discussion took off. And I think this is, something with the field. And we've been discussing this on the podcast. I think a lot of it on the conference was around there. This is the crucial aspect for the field. We're seeing 2 positive phase 3 trials reporting, and drug development is just slowed and hindered by linking the entire process to liver histology. So the field really aims to move forward to have an NIT that predicts outcome as an acceptable surrogate for conditional drug approval.
Which, as was pointed out in that meeting, has a whole bunch of challenges embedded in it, right? So one of the points I think Donna made that's important to note is that when you get into how drugs get used and not how they get approved, you start to shift your focus from what the regulators need to what the payers need.
Yeah, that came pretty early in the discussion. And the way Donna phrased it was, I think the field is struggling how you want to tackle the regulatory, but there is clearly much more to that. And I can't say it in her words. Payer acceptance was one thing that the pharma also brought up, but I think it's through the work that GLI has been doing with the administration, the regulators, politicians, that she highlighted. Of course, there are many obstacles, and as long as the field struggles to define the pathway forward clearly, we cannot speak up as a field and say what the patient and the drug development perspective and needs are, and then it's difficult to drive that agenda. So I think her call for action was to really come up with a strong voice and speak as a united group here to be able to develop that through regulators, through the administration, through politicians, and push that agenda jointly.
As I'm listening to you, I'm remembering what the second abstract that Stephen presented was, and I think it's highly relevant, which was the Lanny work around ALT at 4 weeks being predictive of non-response at 24 weeks. The reason I mention that is that implicit in what Donna said is that because the questions are different, the pathway is going to be different. So one of the things we've started to talk about in this meeting, and we talked about on this podcast, I guess on the last conversation, which is going to be part of the same episode, is we've got to do a better job of figuring out faster who this is not working for in order to get payers really comfortable. We talked in the last conversation with Scott about the idea that there have now been 2 drugs that have demonstrated that you can take a look at adiponectin and figure out fairly quickly if you're getting response or not. Stephen shared the ALT data around Lanny, which is really, I think, important, because if we can figure out by looking at an ALT in 4 weeks whether you're going to have response in 6 months, then that may not over time turn out to be a perfect predictor, but it should be a pretty darn good one. And it will give payers some level of comfort that they don't have to wait a year and a half to figure out if things are working or not.
I would say the concept is important, right? Because the way we look at it now, getting a surrogate liver histology after a certain time and then after over a year seeing the drug didn't do anything is, of course, spending a lot of money on something that doesn't help, potentially giving side effects to the patient. And there is a big need to identify a response or non-response early. The abstract he presented was data on 4 weeks. Again, I think that's a little, that might not be the right time point for all drugs. And then the discussion, they also said, they didn't have any other data points at this time. Mm-hmm. But it clearly speaks to the need to have a companion biomarker for your licensed drug to decide on early drug effects. And I think that's very useful for the payers. So I don't think you have to be afraid that you can't sell your drug anymore. I think it's going to support sales or aspects of market penetration if you actually have companion diagnostics help guide physicians and patients out. Now, in an off-mic conversation, somebody, and I forgot who it was, mentioned to me that this might be more relevant in Europe than in the US, where physicians just like to prescribe and the patient takes the drug. So somebody seemingly was under the impression that Europeans like to monitor that a little bit closer than the US colleagues, but I'm not sure that holds up for everybody.
Jörn, I think the presumption, taking the American point of view, is that you guys manage the money around healthcare more carefully than we do. And as a result, that must mean you're going to, and I don't think it works that way, but from our viewpoint, it must mean that, look, go back to the Mike Charlton slide in the first presentation where he said that there should be 16 million people in the U.S. with NASH seeing doctors. Okay. Call a drug $10 a day. just to pick a number. That's not out of the ball. That's not outrageous in either direction. That gets you to with 80% compliance, maybe $2,500, $3,000 a year, $3,000 a year, 16 million people, $48 billion. Right. We're not going to pay that. So it means that we've got to do a good job of figuring out who needs to be on drugs, and also are they working faster or slower, which gets you back to, and I think you're right, I think payers will be far more comfortable with a prescription if they can figure out if they're getting value for their money quickly. Because one of the other points that was made during the roundtable is that payers aren't accustomed to 10-year payoffs. They're accustomed to 2-year payoffs. And there's not going to be a 2-year payoff on these drugs. Even with compensated cirrhosis patients, you might not have a 2-year payoff. And certainly at F3, you're not going to have that. So if you've got a long-term payoff, which makes people uncomfortable for a 25% efficacy drug, where you can't figure out for a long time whether the drug is working or not, that's not attractive.
On both sides of that coin, yes, the European market might well just prescribe, but they won't have the necessary figures. I think what the US care system does, because of the insurance payers, is actually track the cost very, very well. One of the strengths of any change of medications in patients is the improvement in quality of life, the improvement in energy, the improvement in the associated costs of the healthcare that's being provided to those patients. So therefore, you can do the cost extrapolation, and certainly things like sleep improve very, very quickly when we defat the liver, the energy levels, the quality of work that person puts in. That actually does not take 2 years to see in patients. And if you're in an insurance market, if you monitor these figures well enough, you should be able to see a level where you bring down you've got the cost of the drug coming down as you've got the improvement and the reduction of costs of patients' healthcare provision and appointment. Because you put them on longer appointments, you interact less because you monitor less as they become more stable. So I think that you will see this sort of wave and the crossover of that. We will not be able to track that in Europe. And certainly from a British payer's perspective, you've got to prove in advance the cost that your savings. You can't do that in our system because of the way that is done. And most people don't stay in a job more than 6 to 9 months in those levels. So we have huge problems in being able to do that and drive initiatives to take that leap of faith. What you will see is a reduction in healthcare costs over time. The more people we get into that, the greater the cost care reduction, particularly in improvement of diabetes control and cardiovascular and all of those metabolics. So I think potentially you will see a mass savings. So if I was an insurer personally, my shareholders are going to be really interested if I'm not laying out costs in diabetes, heart disease and fatty liver, but I am incurring a cost of a medication because you're going to get paid back. We know that. All of the figures of all of the evidence that people have put in just to how we can improve health. You look at the bariatric surgery, it all proves that liver health and all the cardiometabolic components improve. That's where we will see the cost, but it's got to be set to do that with correct ICD-10 coding so that we can really get these people in quickly to look at that. So I think there's a strength to the US market and potentially Australia, who for me operates a similar system.
Although you are asking actuaries to take inductive leaps at that point, which is challenging. I mean, people are accustomed to doing hard numbers in ways that are easily measurable. And what you're asking now is for transference and inductive leaps. And, that's always been a hard thing to do. I mean, just to give you a simple example, you present proof to people and you tell them that you're saving 0.9 head count. And they say, I can't save 9/10 of a head count. That counts as 0 to me. So it's not exactly the same thing, but it's similar, which is that people in those settings on the insurance side deal with very, very brass tacks numbers, very firm numbers, very linear numbers, non-inductive numbers. So it changes a little bit over time, but there will be challenges. And that's the place where one would hope that aggressive patient advocacy can have some impact. So, Jörn, what else struck you about the regulatory?
Well, I think, when the course directors flagged out they wanted to improve each year and they want to make something better. And thinking back to that fireside discussion, I think the payer was missing and the regulator was not there this year. And again, these two groups are difficult to involve. You can't get them online every year. I think there was recent exchange during the Mosaics initiative in Washington, which went well and covered some of those aspects around the drug development endpoints using NITs. And I think there was a clear feeling that there's more dedication. If you have the data in your drug development program, the regulators are going to look at that and accept it potentially to support your drug development program. But again, the payer was not there. And from a personal perspective, I think those are difficult to reach out to. And again, there are different systems, as Louise just highlighted also different groups, but it's something that could come up for next year's discussion.
It's a funny thing, right? I got involved with fatty liver in the first place because in 1919 and 1920, they did commercial sessions at NASH-TAG to ask about commercial issues. And those were packed, okay? I mean, packed, a smaller meeting, but I was the last thing between people and dinner on Friday nights of both years, which is the late night. And the people in front of me ran late, so I was the last talk. And the first year, when nobody had any reason to know who I was, nobody left the hall. By the time I was halfway through explaining to them that the market models didn't work the way they thought they would, nobody was on their cell phones either. So I think there's a thirst for all that. And Jörn, I agree with you. I think they need to figure out, it's hard because payers and look, I think one of the things that happened last year was that the regulators in the Fireside Chat might have gotten out a little bit over their skis and then had to deal with the consequences of that in conversations throughout the year, right? I mean, and in Paris NASH, the things that Prekka and Ania said, people thought that might have been a step back from where they were in NASH-TAG, and I don't know that it was or it wasn't, but that's what happens when you have unscripted conversation. Payers are also very afraid to get out over their skis in those settings, and by the way, payers tend to speak for themselves, not for everybody. Somebody from ICER would, I think, be a real benefit. And in fact, a session that included somebody from ICER and somebody from NICE might be a really cool session to throw at something like this in terms of taking a look at how are different folks going to broadly assess, and someone from EMA or one of the German funds or something to take a look at, okay, so how's health assessment going to get done? And while we're worried about getting drugs approved, what should we be thinking about next?
We should draft that session and send a note to them in case they're not thinking that way, but I think they should.
I think the other people who aren't in the room are the allied health. So we have no nurses in there. We don't have any physios. We don't have any nutrition. I don't know whether Ashira was there. Allied health is a large percentage of how this is going to be distributed, and yet they're not in the table, either in NASH-TAG or that's important. And there was a fantastic presentation which underlined how little evidence we have in liver imaging for spleen and liver volumes by Claude Solin. And he was very key. Invite us. We want to be here. That's the conversations that need to go on. If NASH-TAG wants to bring everybody around the table, we need allied health there. The same with the pathway in Barcelona. We need now to be all around that table.
Louise, as you know, I violently agree with you on the general subject. This meeting I'm not as sure about. It's a different meeting. It's really a drug development meeting. It's not a pathway meeting per se. It's really a drug development meeting. It's what research should we be doing and what are we learning about how to do the research better. It's not that allied don't have a role, but it's that the places where allied are most important are, I think, more tangential to what they're trying to do here than in any other meeting. Like I say, if you can't get them to talk about commercial and you can't really get into the meeting right now, numbers about the health economics of what we're doing, then to slide over to allied is kind of one step further down that path. I don't disagree with you that it's important. I think it's going to be a harder slog given how far you'd have to shift the focus, if you will, to get there.
The way where I see it, Roger, and I'm going to put on my pathway hat here, and I'm really looking forward to our meeting in Barcelona end of May, is when we have a drug, it might be different in the different systems, but I think the allied health professional could be the one managing some of the side effects that patients are experiencing, giving advice to either maintain the patient on drug to achieve efficacy, or deciding, this is one of the patients I'm going to take off drug early. I got to say something to my physician because the patient is not holding up. Side effects are so strong. And I think the drug management, and Louise, please correct me, I don't think it's not the allied health physician that makes the call, but I think it's the support around drug management that could be very important.
I think that's important. If we take hepatitis C as an example, I had 10 consultant physicians. Every one of those consultants would refer their patients into the nursing delivery of hepatitis C care, and we would hand the patient back at the end of treatment. They all had a piece of the pie. The way that the nursing system worked, we had the whole pie. That's the difference, is that we did all of the coordination. So literally, unless there was a problem, and now you have nurse prescribers and pharmacy prescribers who can do that sort of area. This is where, within a hospital, if you look at what Jörn was saying there, I could be running a cardiometabolic referral system in for fatty liver disease. But if they're not cirrhotic, they won't be in my hepatology department. They may well be from my HIV sexual health. They will be from rheumatology, where they'll methotrexate. Unless they have a reason to see a hepatologist, they won't be coming. But I would have that whole piece of pie running that service and system, and that's more cost effective and coordinating. So that's exactly what Jörn is relaying, in the fact that you won't necessarily have everybody in hepatology, but what you can have is an area where everybody goes. And that could be any allied health.
Agreed. And I guess the point I'm making is that belongs front and center in Barca. It belongs front and center at NAFLD Summit. But Jörn, you were there at Paris NASH last year. They did a presentation on supporting patients and somehow got through a 3-person panel and nobody said the word nurse or allied health professional, to the point where I got up and asked a question, which I don't usually do with these things, and said basically I was channeling you. And my channeling you was, how do you have this conversation and not talk about allied health professionals? At which point someone on the panel embarrassedly said, yeah, you're right. My comment was kind of specific to this meeting, that I'm not sure that's where this meeting goes.
No, I suppose you're right for the presentation side of it, but maybe it's because I get access to this meeting as a nurse. I really enjoy the data, the conversation, the way it leads me to think about pathway delivery and to raise some of the questions that wouldn't necessarily be questioned at an academic meeting, but could take you in a different direction to answer those points that sometimes get missed in an academic rich area. And that's why Donna and the patient advocates bring a different perspective, because it brings us back to, we never thought about that, but that can change how you deliver a drug. That can change how you view how you're going to take that pathway out or how you're going to invest. Because you could have the best drug in the world, but if you've never thought that it's going to be practical to bring it out of that area. So it is a crossover. But for me, it's about the data-rich discussion that I listen to in the room. It's not so much about me presenting or a nurse, a consultant, and there's a number of excellent nurse consultants and practitioners in America that can do that.
There are 2 of these aspects we should bring forward to the directors and actually make concrete suggestions. And actually, I think one thing is they should join us on the podcast and, give some of their insights next time. It's amazing for me. This was really one of the highlights to kick off the year. I'm afraid I'll have to go catch my transfer soon to start traveling back. But the discussions, also just the 3 of us here, thinking back of all the great sessions, is very stimulating. And I think the meeting, as the organizers intended it, will set the stage for a great year of 2023 in NASH, NIT, and drug development.
We agree. I'd like to leave one more dangling question before you go, which is, and it goes back to Louise's point. As I understand it, that room was packed. Now, I've been there in the past, okay? But Scott, for example, who's been there every year, was saying that the room was totally packed. They don't want to leave Deer Valley. Forget they don't want to leave Park City. They don't want to leave Deer Valley. And that's the biggest room in Deer Valley, and that's how many people you can put there. So as interest grows in NASH, either they're going to have to figure out how to keep this going with 250 people in the room, or the adjustments they're going to have to make. The thing it reminds me of is the Society for Immunotherapy and Cancer, which used to be the kind of meeting this used to be. And then Keytruda and Opdivo hit, and the whole thing changed.
I agree. And maybe the one point is there could be a little bit more diversity in the faculty. And I think they'll get the feedback also that the field is growing. I didn't know it's the biggest room here, but I'm with you. They had to put chairs in the back. I mean, if this takes off further, the room, it needs a spillover.
Well, yeah, there's probably a convention center down in Park City or something that you could use, but I'm not sure that they want to go down to Park City. I mean, they kind of like it the way it is. So I think that will be a challenge for them. At any rate, yeah, I agree. A fantastic meeting. I'm sad. Well, Stephen was with us, but I'm sad the others weren't. I'm going to try to see if we can, sometime in the next couple of weeks, get at least Mike to come join us and talk a little bit more about his experiences with the meeting. So you're in safe home. We will be posting this episode later today. We'll be posting an episode on Wednesday with some follow-up from the meeting. Not entirely sure yet who's going to be joining us for that, but we've got some industry people who are interested, and hopefully Quentin will be able to join us for that and if he doesn't, we'll see who can.
Thank you, guys. Looking forward to be speaking on the other side of the world next time.
And hopefully you'll be awake enough at that point, and will not be just completely jet-lagged out. But we look forward to seeing you tomorrow. Louise, see you tomorrow.
See you later.
Everybody, take care.
Bye.
Bye-bye now.
For our final conversation, Jörn and Roger are joined by HistoIndex Chief Scientific Officer Dean Tai to discuss the poster Dean and Jörn presented at NASH-TAG regarding zonal and liver volume-corrected analysis of fibrosis and steatosis.
Jörn and I are here with Dean Tai from HistoIndex. Dean, depending on where you are in the world, it's either morning, afternoon, or evening. Speaking to where you are, how are you this evening?
Good. I'm in Brisbane, Australia now, so it's evening for me. It's been a wonderful day. I'm just going to get my Christmas celebration started, actually.
Very nice, very nice. And then in the middle of the day, sounding fresh as a daisy, we have my colleague, Jörn Schattenberg. Jörn, how are you this afternoon?
Hey, Roger, I'm fine, thank you. It's the day pre-Christmas Eve. As you know, we are celebrating Christmas Eve over here with a family predominantly recently, and we're having a little pre-Christmas party later tonight. So very excited and looking forward to that. And then, of course, excited to be here with Dean, who we've been doing some great work with, and I'm happy to talk on that.
And then where I am, it's 7 a.m. in the morning, and I am on my second cup of coffee, and hopefully don't sound any worse for the wear. But what Dean has brought and Jörn have brought with him today, I think is really some fascinating material. Up until now, up until literally Monday with the release of the Maestro-NASH data, the question has been, can we find a drug that hits the finish line on efficacy and safety at the same time? And these have been scored using really some pretty crude measures, right? Regression of biopsy, wherever in the liver the sample comes from, and NAS activity score. But as we start to get to more late-stage clinical trials with drugs that are successful in meeting these criteria, the question ultimately is going to be, so what do they translate into for the liver and the metabolism over time? And here, I think Dean and Jörn have brought with them today some data that will shed an interesting light on ways to ask and answer that question using AI histopathology. So without any more ado, let me turn the floor over to, I guess, Dean to start us off and talk a little bit about what you brought with you today, and then Jörn will talk about the results, and then we'll all ask questions. So, Dean, your floor, my friend.
Thank you, Roger. So what we have recently found is some intriguing data about steatosis and liver volume reduction from aldafermin as well as the resmetirom. These are the phase 2 trials. So we have seen that the fat and hepatic fat has been significantly reduced in a very short time frame, as little as like 12 weeks to 36 weeks in these two studies. And the question we asked is that, does the fibrosis change as fast in this time frame? And most people will hypothesize that the fibrosis regression will take longer. So the question is, in that scenario, what happens to fibrosis reduction? So our data basically using AI to measure how the fat change, how the liver volume change in these patients, and how the potential impact that can have fibrosis. And are these somehow navigates the actual fibrosis change that affected the 1-point reduction gold standard that we will look for? So these are some very intriguing but very exciting data. So we're very excited to share this data with Roger.
Dean, thank you. And I agree with you. I think there's a certain excitement around what you're ready to discuss with us here, because looking back, we've seen some trials with a very short duration on very effective defattening of the liver, 12 weeks. And something that was reported was relevant fibrosis reduction. Everybody then asked, how can that be? Fibrosis is slowly moving. Is this a true effect? What happens? And I think the point you're making here is that fat reduction changes liver morphology, liver size. So when you take a piece of liver and look under the microscope at it again, then all of a sudden fiber arrangement not being separated as strongly by fat-laden hepatocytes could be very differently interpreted by the pathologist. Could go both ways, I think. And by dissecting the liver histology slides, what you're pretty much doing with your technology, by looking at it in more depth and subsegmenting, looking zonal distributions, looking at quantitative changes, I think is the next level to understand what's happening in the liver. And I think that's why I'm so excited to learn more about that and discuss the data. There's been a good example. If I just look at the slides, and some of that data we're discussing here hasn't really been presented. Some of it was shown by Stephen Harrison during a breakfast meeting you held at AASLD, but I'm excited to share that some of this will be presented at NASH-TAG. So whoever's interested, stop by and have a look at our poster. The data that is being shown is going to be one based on the cohort 4 of the 24-week aldafermin phase 2 study, where by applying Q fibrosis and Q steatosis, you can show that there's actually comparable results between the pathologists if you use the categorical staging. But once you move to continuous evaluation of changes in liver fat and liver fibrosis, there's certain differences that you can say. And again, it speaks to the way we assess liver fibrosis in categories today to assess if an improvement by one stage has occurred. And while these are pretty crude stages, a lot of things happen in the liver which are then better captured by the continuous variable. Now, it's important to mention that this has not been adopted by the regulators, of course, but these observations on ordinal changes are, of course, relevant to the pathophysiology. And for that, I think there's a lot of truth in trying to explore and understand that better. Do you have any thoughts on that or any comments? And you've been instrumental in developing this technology with your company.
Thank you, Jörn. So maybe just share a bit more specific of what we did. We use AI to really normalize steatosis reduction. So AI being widely accepted assessing steatosis in liver. And another advantage is that AI can help us to dissect liver into zones like the periportal zone, pericentral zone, zone 2, etc. So what we have done in the aldafermin is that you mentioned that using fully quantitative assessment, we can see now a statistical significant fibrosis reduction. But with this detailed assessment with the steatosis correction and the zonal analysis, in fact, we found that the statistical significant reduction of fibrosis is most potent in the periportal region. So these are the kind of assessment that the AI can help to find at a very reproducible manner. And these are the kind of things that are not being taken into consideration when we talk about fibrosis staging. And then with that, we started looking at this in all the fibrosis parameters, comparing. Now we're looking at the aldafermin as well as the resmetirom. So what we have found is something really intriguing. In the aldafermin study, we have found that once we applied this steatosis correction, most of the fibrosis changes in zone 2 and central vein, around central vein and pericentral. They are highly statistically significant. Okay, when we apply the same methodology on resmetirom, again, we see very significant fibrosis reduction across the board. But this time, where we see that happens, it happens also in zone 2, but not so much in central vein, but a lot more potent in the periportal and portal area. So we see very two distinctly different fibrosis regression pattern in these two cohorts. They are both statistically significant with a very potent fat reduction. But once we corrected this, we found a very distinct fibrosis regression pattern. So that to us is very intriguing and very exciting.
So speaking, just comment and question, and then Jörn, back to you. Speaking as a guy with minimal science knowledge, but a fair amount of statistical knowledge, the first reaction I had to this is that consistent with what AI is supposed to do, you've actually taken fibrosis regression, you've dimensionalized it, right? Which is we're now not just looking at a number, but we're looking at a map of the liver. And you could almost, right? And you could almost color code hot zones and cold zones based on exactly how much regression you're getting and where you're getting it. And that these techniques enable you, therefore, to visualize the liver treated by aldafermin and the liver treated by resmetirom as being two different livers almost, if you will, or two different visualizations of treatment.
Yeah, exactly. I think the way you pointed is really, we are an annotation tool. Basically, you highlight where you want to measure. And I think to some extent, pathologists has been doing that. In fact, when I have this conversation with them, they are not surprised. They saw that very often in all these trial samples. Just that the CRN system is kind of a limitation because at the end of the day, they can only record F1 or F2 or F3, F4. They can make all the remarks they want. In fact, a lot of them did this with a lot of remarks, but they are not taking into considerations at the end.
This discussion around high-end precision assessment of liver slice is really fascinating because we've been complaining in the field that we're using very blunt tools, a needle, pulling out some liver histology and then categorizing it in 4 buckets when trying to assess response. Now, that response has been shown for the second time in a phase 3 trial, speaking even in the bluntest way to subsegment and analyze fibrosis. You do get signals that are stat-sig in those groups. But it's intriguing to try to understand what the numbers of changes in fibrosis are going to end up with in the end if you apply more, and I'm going to use a Harrison quote here, laser-targeted fighter jets and dissecting that, just having a more precise analysis technology. Because something the field always is, or something that I'm always confronted with is, well, you just get a 10 to 20% difference. You're saying it's statistically significant. But it's done on a very rough measure. And I think by applying these technologies, we're going to understand better how much change in fibrosis there is. And that's the first aspect. The second aspect is, of course, we're trialing a lot of different MOAs in comparable patient population. And it seems very logical to postulate that not all drugs are affecting fibrosis regression by the same way, but more specifically on how and where they act. And I can very well understand Dean if he details, we're seeing more pericentral versus peripheral changes and trying to link that to the underlying drug effect is interesting. I'm not sure we fully understand that yet, but it brings us to the next level of deciphering how that drug actually affects fibrosis regression on the big scale, independent of extrahepatic effects.
Yeah, so as as a researcher, not a medical researcher, but a researcher, a couple of things strike me, Jörn. First of all, I think those are excellent points. And I hadn't said this yet. Dean, you guys are to be commended for this work. I realize that I'm becoming at least something of a liver geek when I look at your slides and I start grinning from ear to ear like an idiot. I say to myself, okay, fine. Obviously, there's a level on which this is touching me. And we actually should touch anybody who understands it. So one thought, Jörn, is at that point, if you could get longitudinal histories on the patients whose slides you've got, then you can start to sort some of these issues out in real time in very brass tacks practical ways. That might be too expensive to do. I don't know. But you actually now have the ability to track a slide to a patient, track that to an impact on a zone of liver, and ask, okay, what have we really done here for the patient, which is ultimately where the rubber's going to meet the road. It's Stephen's fifth level precision strike fighter mode. I think that's right. The second thing is it raises a really interesting question to me, at least, around drug development going forward, right? Because if you adopt a model that says we're going to have over time induction drugs and maintenance drugs and monotherapies and combination therapies, then one of the questions has to be, where do you want to have impact on liver and how much at which points in time? And by having an opportunity to map the liver geographically, I think you can do a much more efficient job in figuring out how to put combination therapies together. And beyond simple things like what's injectable and what's oral, figuring out what makes sense on an induction mode and what makes sense on a maintenance mode. Dean, can you comment on A, is that correct? And B, how do you see that evolving in terms of practical evaluation of data and the kinds of studies that people might be generating going forward?
So this is what I think. First of all, the quantification data of all these different zones. That's what we're doing now. We're correlating to clinical outcome. The most recent data in New England Journal is that we have further confirmed that fibrosis staging linked to clinical outcome. There's a lot of solid proof. Now, but this is the case is when there's intervention, then how much change is there? So this is the time really we need more precise measurement, because if you go back to the full bucket, while we ask all these questions, it's very difficult to answer unless you get probably a 10, 20 times more patient follow-up at that time. And that doesn't really benefit for drug development later on as well. So I think this is really not rocket science. We need more precision data measuring the right parameters. Now, my view is how this will impact the ongoing clinical trials, drug development. I think you brought up a very great point about, how do you compare oral versus injection dose and then have different MOA. Eventually, we want to give, we want to balance, have the right dosage. And this is where the detail comes, because I think as it is, we see the 1-point system. It's very difficult, but we're happy that now we have a phase 3 trial meeting the top line. And now when we go into further dissecting multiple combination therapy, then we see the challenge there. Now, if we can imagine, right, we can have one drug really having periportal fibrosis while associating steatosis and inflammation reduction, then it really helps us to not only design a more scientifically sensible endpoint and also a more measurable surrogate endpoint. This will actually help to expedite the drug therapy development. And as I move forward, I can imagine, because right now we're talking about an entire metabolic system, so how this will interact with other metabolic disease is another layer of questions just surfaced. So these will be they later take into consideration as we move on to a further consideration of other metabolic disease. That's my opinion. I'm an engineer. So I'm really visualizing more on how the data analysis, not so much on the biology side. So what do you think?
I agree. You're making a strong argument for having a very well-refined drug development tool, mostly looking, I would say, in phase 2 data, looking at the patterns of fibrosis regression you're seeing here. So it might not even be that we need the regulators to adapt this type of technology for drug approval. I think it could support it, but that's a little longer shot. I think the way where we use it, or where I would see its strength, is trying to combine mechanisms where we see either synergistic or complementary effects, and both could be feasible. If you're shown something in the zonal analysis, you get a strong effect in this area, but not in this. Well, why don't you add a drug that has an effect in the same zone to really clear that up? Or you can make the hypothesis, the theory, I'm going to add a drug that has a different zonal effect to get a more broad effect on the liver. So from that perspective, I think it's fascinating, and it's really making most of the tissue that the patient donates, right? Because the way we use it today is it 0 or is it 4, or where does it fall into the buckets? And there's so little compared to how much information is in there. We're not using it to the fullest extent. And even from a research ethics perspective, I think we owe the patient that we take most of the data that is available available out of their tissue and put this into future drug development.
So, Jörn, you make an interesting point. I'm reflecting that it's December 23rd and that Louise has already begun her Christmas weekend celebration and can't be with us today. But I will be the voice of Louise for a second on the last thing you said, which is, we ask so much of patients when we ask them to give tissue. And we have a moral obligation to make the greatest benefit of every piece of tissue that we're given. So when you talk about the kinds of things you're doing here, you're making each patient's individual contribution so much more valuable and thereby showing respect to the patient, which is, at the end of the day, what we're all here to do anyway. So I think that's really an interesting point, not one I would have thought about until you said that. So thank you for that. Dean, where next? What do you see the next steps forward on the path as being here?
That's a good question. I ask myself that question every single night. So right now, this liver volume and steatosis reduction is very new to us. So we are raising more questions than answers right now. But I think the first thing we will do is we will need to correlate all this to clinical outcome. Long-term clinical outcome. With that, we are working with regulatory agencies. We're working on multiple cohorts. These are serial and some of them multiple serial biopsies with patients with 10 plus years follow-up to link to clinical outcome. And I think this really help us answer the question whether this zonal and effect has similar or even better predictive value to the fibrosis staging. Okay, I think that's the first one. And then the second one is we definitely need to validate this in a lot more different MOAs so that we can have a better profile to design a better tool for ongoing clinical trials. We have been, on top of this, we've been developing a lot of visualization tool because the things we have seen, they are relatively complicated, like this steatosis impact on fibrosis, where the zones are. So we will, in fact, we have a poster in NASH-TAG and we will present more data in the upcoming Asia-Pacific meeting and of course the EASL meeting to show this visualization tool. For one example is the radar map. Like all these specific parameters we spoke about, there are many tools like radar map. You can see multiple dimensions of fibrosis changes. So it's not just a 1 point reduction. You can see whether the periportal is going up, pericentral is going down. And another thing is we're looking at the concomitant effects. How is fibrosis affected by steatosis reduction? And our most recent work in ballooning, we are looking at how does fibrosis interplay with ballooning. So all this information are now being just surfaced. So we are now working with a lot of the key opinion leaders like Jörn trying to answer these questions. So I think in short, we are going to show everyone more exciting data very soon.
That's the great thing of being able to look at all these trials readouts now and looking at different MOAs. I mean, the way what's been shown now and discussed during the breakfast meeting at AASLD was phase 2 data from resmetirom and the aldafermin, but there are more drugs and it'll be very interesting to learn actually which one affects this in what way. And I agree with you, Dean, here. This is going to help the field and move it forward, not in the end when we're going to prescribe a drug, but on the way to refine better drugs. And I think even after the second positive phase 3, there is room for improvement and there is need to refine MOAs.
Well, I think both of those are true, right? I mean, if you know that you're dealing with a 3x improvement on a 10% placebo rate, then one way to look at that is that 70% of patients aren't being adequately resolved by an agent. If you take two agents, each of which have, say, a 20% improvement on placebo, then if they're redundant, that means 70% of patients are unaddressed. And if they're not redundant, that means 50% of patients are unaddressed. And the truth is somewhere in the middle. And as you add more and more modes of action and more different permutations of interaction into the mix, you get to a point where you can start to map out how many patients can we successfully treat with the MOAs that we've thoroughly evaluated. And then I guess even beyond that, Dean, I guess if you think of this as a map, you have then the ability to do gap analysis and say, okay, here's the zone in the liver where we need to get an MOA that has an effect because we're not dealing with this, and we know that when we don't deal with this, here are the bad things that happen. I can see all that out in front. You mentioned 10-year longitudinal data. Does that exist right now? And if so, for how many patients, and how are you going about gathering that going forward?
So that's a work in progress. We're working on multiple cohorts as we speak. So the good thing about biopsy is that we can get them from the archive. So with our analysis, we actually do not do staining. So we can return the specimen afterwards. So we don't need to really sacrifice the specimen to do it. So with that, we have some preliminary exciting data. And we will share them next year. And right now, the preliminary data looks very promising, which frankly is not surprising to me because fibrosis linked to outcome that's already clear is that which fibrosis linked to outcome. That's what we are explaining right now.
Again, it's for me self-explanatory. self-explanatory that looking at fibrosis patterns, correcting that for what happens in the liver can give you more granular answers. And I'm sitting down with my pathologist every week to look at all the biopsies I did. And there is so much data, even after years, that you can get from a liver sample. And using AI augmenting the readout is one very logical step and one that I'd like to develop or see develop further, among others, through HistoIndex and Dean here for drug development.
Your last comment points to the rather interesting idea that goes, we have tons of data, not me, but we, the researchers and the companies, have significant amounts of data that have only begun or not even begun to be plumbed to the kind of depth that we're talking about here. So the value of what the work that people have done in the past can be fairly dramatically augmented by going and doing this even as a retro-analysis on data that exists. The way I took your comment was that we don't even need new studies, although new studies are important, but we also have the ability to reevaluate old data in a different way and gauge the impact of that as well.
As an engineer, I totally agree with you because there is abundant data. When we look at these samples, they are like gold mines. There's so much information, and I think we are all surprised that there's so little information is being used. And biopsy, these are visualization. These are images. They're very intuitive. When I share with you, this is periportal and this is how the fibrosis change. Once you visualize it, it becomes so intuitive. So the question when we talk to regulatory agencies is really, when you have intervention, what are the potential impact? For example, if at this point we say 5% reduction in periportal fibrosis can link to clinical outcome. But when intervention comes, is it still 5% or do you only need 4%? So we do have some questions that we will need to address. And at this point, I think no one has the answer to that. But I think that point us, especially with the recent good news from resmetirom, this is showing that this is achievable. And this data that the 5% versus 4% question, we now have the means to answer it now.
So that's super. And I think very, very exciting. And posting this interview as part of our coverage of what promises to be a really exciting NASH-TAG, I think might wind up being the cherry on the sundae or the icing on the cake of our, sorry for using sugar metaphors, folks. I know that's a bad thing to do in fatty liver disease.
We all run on sugar, Roger. It's the balance, and you got to, of course, burn that sugar again at one point.
It's a good point, Jörn, although frankly, to completely personalize this, all you need is one lymph node full of melanoma at one point in your life, and you start to understand exactly how toxic sugar is. Not in the liver context, but nonetheless. Some of us are sugar junkies and then understand how bad that is for us. So I will search for a different metaphor. Okay, this is the extra spice on the banh mi of liver disease. How's that? Is that better? Big banh mi fan. So, but whatever metaphor we want to use, this is at the end of what's going to be a fantastic conference. And Dean, thank you so much for bringing this information to us today. I can't wait to see what you all come up with next.
Thank you, Roger.
Yes, thank you. And stop by our poster at NASH-TAG if you're there. I'm happy to discuss further.
Thank you, folks. Have a Merry Christmas and a happy holiday season, however you celebrate it. We're looking forward to an exciting 2023. Bye-bye now.
This episode of Surfing the NASH Tsunami, including the accompanying discussion on zonal and liver volume-corrected analysis of fibrosis and steatosis, has been sponsored by HistoIndex, the world's leading specialist in stain-free imaging for NASH clinical trials. HistoIndex is transforming diagnostic standards and drug development for NASH with its second harmonic generation-based AI digital pathology solution. Thanks for listening to today's podcast. Please join us Wednesday evening when a roster of multidisciplinary stakeholders join Jörn, Louise and Roger to discuss the key points and broader implications of NASH-TAG 2023 here on the Surfing the NASH Tsunami podcast. Have any questions for the surfers? You can send them to surfingnash.com and we will answer on the podcast or the website.